In 2013, pertuzumab was FDA approved for the neoadjuvant treatment of HER2 positive early stage disease, tumors greater than 2 centimeters or lymph node positive, when combined with trastuzumab and chemotherapy. This was the first FDA approval of a neoadjuvant regimen for breast cancer. But at that time, we didn't really have long-term outcome data. We didn't know if the addition of pertuzumab was improving event-free survival or overall survival in patients who received it. And the standard at that time was to just give the pertuzumab prior to surgery and then just give the trastuzumab in the adjuvant setting as standard of care. Affinity was a randomized large phase 3 clinical trial that looked at the full year of pertuzumab in the adjuvant setting when added to trastuzumab. The Affinity trial showed that there was an improved disease-free survival, invasive disease-free survival, associated with the addition of pertuzumab to the standard regimen. However, in updated results that were presented here in 2019 at San Antonio, we see that that benefit in invasive disease-free survival does appear to be restricted to those patients who have lymph node positive disease. So in my own practice, I am utilizing pertuzumab for lymph node positive breast cancer that's HER2 positive rather than lymph node negative. Whenever we add another agent to our armamentarium and utilize it for a patient, we have to take into consideration its cost in terms of toxicity to the patient. And pertuzumab has been shown to increase the rate of febrile neutropenia as well as diarrhea when added to a standard chemotherapy trastuzumab regimen. It's not a large increase in toxicity. It is something that we can manage, but why increase toxicity if there's little chance of benefit? So when I'm putting together a patient's regimen recommendation, I discuss with them the risk of their disease. Are there lymph nodes involved? Is this high grade? What is the size of the tumor? How healthy are they? And take all of these factors into consideration when deciding whether or not to use pertuzumab.
The Catherine trial was designed to determine whether using TDM1 in the adjuvant setting was superior to trastuzumab in patients who had residual disease after receiving standard HER2-directed neoadjuvant therapy. About 1,500 patients were enrolled. All the patients had received standard neoadjuvant therapy, but had some degree of residual invasive cancer at the time of their surgery. And they were randomized then to either standard of care, which was at that time 14 cycles of trastuzumab, or 14 cycles of TDM1. The idea was that perhaps TDM1 could help overcome some of the resistance that was seen after standard therapy. And I think everybody was quite impressed by the results of this study, which demonstrated essentially a 50% improvement in essentially all the major events, both disease-free survival as well as distant recurrence-free survival, favoring TDM1 over trastuzumab. And essentially all the important events were improved with one exception, and that was patients who had CNS recurrence as the site of their first event. That wasn't that surprising, since we know that TDM1 does not get into the blood-brain barrier that well. It is an important issue that we're going to have to further develop therapies to improve upon. But overall, clearly this was a very impactful study. It provides a great option for patients who do have disease that's not quite as sensitive as we would like to standard HER2-directed therapy and chemotherapy in the neoadjuvant setting. In general, TDM1 is fairly well tolerated. I think most oncologists are fairly used to using TDM1 in the metastatic setting, where it's been approved since 2013. And what we saw in the early disease setting was pretty similar to what was seen in the metastatic setting. So mild fatigue and nausea were were seen, typically did not result in discontinuations. Overall, I think about 18% of patients had to discontinue their TDM1 before they finished the full 14 cycles, but most patients, did well. And the reasons for discontinuation were liver function tests, abnormalities, and thrombocytopenia in some patients. But again, that was not very common, and overall, I think TDM1 was fairly well tolerated.
Another agent that's become available for use for HER2 positive early stage breast cancer is Neratinib. Neratinib is a pan-HER inhibitor, tyrosine kinase inhibitor. It's a pill, and it's not specific for HER2. It also hits EGFR to a significant extent. And because of that, there is toxicity associated with it, namely diarrhea and sometimes rash. This is a powerful drug. It's more potent, we think, than Lapatinib, and its evidence has shown that it might be more effective. From the NALA study in the metastatic setting, it appears to be more effective than Lapatinib-based therapy. So the ExteNet trial was a phase 3 clinical trial aimed to look at a particularly high-risk patient population in the adjuvant setting and address whether or not adding a year of Neratinib after completion of the standard year of trastuzumab would improve the invasive disease-free survival for patients with HER2-positive breast cancer. And indeed, they did show the invasive disease-free survival was better in patients who received that 1 year of Neratinib, but the benefit seemed to be largest in those patients that were node positive or had hormone receptor co-expression. Keeping in mind in the adjuvant setting, patients whose tumors are both HER2 positive and hormone receptor positive will receive endocrine therapy to block the hormone pathway of that tumor cell. Another backup resistance pathway when the hormone pathway is blocked is the EGFR pathway, which crosstalks with the hormone pathway. So the thought is using Neratinib with the hormone therapy and the HER2 blockade part of Neratinib may improve outcomes for patients. And indeed, in this trial, it was the hormone receptor positive patients who seemed to derive most of the benefit from Neratinib, especially when lymph node positive. We have to keep in mind that about a quarter of patients had grade 3-4 diarrhea, which is really clinically significant diarrhea when we're talking about curable disease. And so studies have been conducted, one of them called the control trial, to look at how to mitigate that side effect. We use upfront use of loperamide. We're looking at things like cholestyramine and budesonide, which have substantially lowered that risk of grade 3 diarrhea and made it more tolerable for our patients who are high risk. So in my own clinical practice, I'll use Neratinib in a high-risk patient who's node positive or has hormone receptor co-expression in the tumor, as long as they are going to be okay with, from a comorbidity standpoint, they're healthy enough to take this drug. I'm very careful with the diarrhea management, especially in the first few months. And I do think it's an effective therapy. There are unanswered questions. We don't know whether we should be using this drug in a patient who's received pertuzumab, so that hasn't been addressed in ExteNet. And now with the advent of TDM1 in the adjuvant setting, we don't know if Neratinib adds any incremental benefit in a patient who receives TDM1.